Welcome to the Health Trip Podcast. My name is Jill Foose. I'm a functional medicine and integrative nutrition health coach. I created this podcast to bring you along as we travel down intriguing, science-packed roads, debunking old medical paradigms and perusing new innovative therapies and modalities with the finest functional medicine doctors, practitioners, and like-minded biohackers while living our best life. Enjoy the show. Hi, everyone. Welcome to another episode of the Health Trip Podcast. I'm really excited about this episode because most of the women I coach are perimenopausal, menopausal, or postmenopausal, and often feel very confused about making a decision whether or not to take HRT, or hormone replacement therapy, and or BHRT, bioidentical hormone replacement therapy. HRT started in the 1960s, but became very popular in the 90s when the first clinical trials on HRT and postmenopausal women were started. It was called the Women's Health Initiative, launched by the National Heart, Lung, and Blood Institute. In 2002, the first results were shared declaring that HRT had more negative than beneficial effects, and thus HRT use was dropped dramatically in the US by about 46%. Years later, the WHI trial was reanalyzed and showed that HRT use in younger women had multiple beneficial effects, including reduced cardiovascular disease and all-cause mortality, meaning that HRT was protective against all ways of dying. And the women in the WHI study were at least 10 years out from menopause when they started the HRT. Needless to say, women are still confused and worried about starting HRT or BHRT and are struggling through this phase in their lives with symptoms such as weight gain, cognitive decline, loss of lean muscle mass, night sweats, loss of sleep, loss of libido, vaginal dryness, osteoporosis, thinning hair, and more. By the time my midlife female clients get to me for health coaching, they've already tried out several diets, take a cocktail of antidepressants, anti-anxiety, and sleep pharmaceuticals, has lost her sex drive, gained weight, lost her vitality, and has low self-esteem. Just as the kids are leaving the nest for college, mom's at home and feels like crap. On today's episode, my guest and I are going to dive into women's health, the misconceptions around HRT and BHRT, and how to best prepare yourself with the current medical data so that you can make an informed decision for yourself. Dr. Wendie Trubow is a functional medicine doctor whose specialties lie in gynecology. She received her MD from Tufts University in 2000 and has been practicing functional medicine since 2009. Through her own struggles with mold and metal toxicity, celiac disease, and a variety of other health issues, Dr. Trubow developed a deep sense of compassion for what her patients are also experiencing. She is passionate about helping women optimize their health and their lives. Dr. Trubow and her husband founded the 5 Journeys Functional Medicine Clinic outside of Boston and offer services such as IV therapy, primary care, women's health, and functional medicine. She's also just released a new book that she co-authored called Dirty Girl, Ditch the Toxins, Look Great, and Feel Freaking Amazing. So before we start on the podcast, just a little medical disclaimer. By listening to this podcast, you agree not to use this podcast as medical advice or for making any lifestyle changes to treat any medical condition in either yourself or others. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any of my guests on my podcast. So sit back, relax, enjoy the podcast, and let's get started. So you're a functional medicine OBGYN, and there's not that many of you out there because I've looked and I'm in a big city. I'm in the city of Chicago and we don't really have any. So tell me a little bit about what the difference is between a regular OBGYN and a functional medicine OBGYN and why, after going through medical school, you went on that path.
Sure. So technically, I'm no longer an OB because I retired from obstetrics in 2009. So I only do gynecology. And I would say in the field of obstetrics, you don't really need functional medicine because that's all about having a mechanical process occur. You're growing a human, it comes out of you. Hopefully everything's safe, easy, and without complication. So you don't necessarily apply functional medicine to OB. What I do though is in gynecology, women can have a range of dysfunction. So if you look at reproductive issues, if you look at menstrual issues, if you look at polycystic ovarian, insulin resistance, there's a whole host of things that trickle into gynecology. And so I would say as a conventional gynecologist, my training was birth control pills, which work really well for pregnancy prevention, but they don't address the underlying cause, which is there's some imbalance that we need to get to. And so when I pivoted to move into functional medicine, I'm still a gynecologist. I still prescribe the pill, and I also recommend things and do a deeper dive and look for like, what's the root cause? Let's figure this out and fix it.
Right, right. I mean, and that's so wonderful because so many people are unaware of just talking about birth control. You know, if you take birth control, you probably need other supplementation to support that because it's going to deplete you in other things, right?
Yeah.
Yeah.
And it also alters the gut milieu. And so it's not the panacea for everything.
Right.
It's good for some things. And then nothing is without cost.
And so within your world of functional medicine, especially working with women, when let's say you take blood work, for example, how does that look different? You know, I know from my own training that in the world of conventional medicine, we're looking at normal ratios based on, you know, the average person. And I, quite frankly, I don't want to be compared to the average person because I take care of myself, right? But I know in functional medicine, we looked at optimal ranges. So can you just speak to that?
Sure. So I always say to my patients, there are things that I will pick a fight with that Quest didn't pick a fight with because they're looking at life or death. They're looking, are you going to die with a level like this? And I'm looking at what is optimal, like you mentioned. And so, you know, we're stricter. Basically, we're looking for what's going to keep you healthy for many, many years. So fine, you can have a CoQ10 that's 0.5, but you're not going to have great energy. So we want to boost that up. We want to see that at least over 1. And if you have a cardiac history, we want it over 2. So we're stricter. We're looking for lower levels of inflammation, higher levels for general, you know, B12. It's so funny. I had a patient, I said to her, you have legit the lowest B12 I have ever seen in my life. And I said, that's not something to be proud of because boring is good. And you don't want to be at the extremes. You want to be at the healthy levels. And I said to her, the consequence of that is that your homocysteine is crazy because you're not processing it and you're not healthy. And she was 78. So I said to her, like, the stakes are high when you're 78. It's not just like when you're 21 and you go, oh, you've 20 years before you have to worry about this.
Right.
This is now. So I said to her, we really need to address this because it's crazy low, but she didn't trigger as abnormal on Quest. Quest still said she was normal, but it was 93. I was like, this is a really big problem. We want this to be above 750. It's an ocean of difference.
Absolutely. Yeah. And so the gist of this podcast is really to dive deep into hormone replacement therapy and also bioidentical hormone replacement therapy, because I'm 54 and I've been in perimenopause now for 4 or 5 years. And yeah, it's a super fun roller coaster ride that I really don't want to be on anymore. But in all fairness, it's been pretty smooth sailing for me because I did choose to take bioidentical hormones and I live a very healthy lifestyle. But there are so many women clients of mine who all have this very similar complaints around this time in their life. So I'm sure you see that too, you know, weight gain, fatigue, cognitive decline, low muscle mass, like all, you know, what else are you seeing out there?
I mean, that hair loss, sleep
Sleep.
changes. I was laughing when you said perimenopause because last summer, our next book is all about how to transition into menopause gracefully. Our first book was about toxins. And then next one is about transitioning gracefully because last summer I was in the midst of a rip roaring hot flash. And my husband chose that moment to ask me a question that I considered to be completely useless and inane. And it was something about like, should I bring the cantaloupe on our vacation? And I looked at him and I said, I'm having a hot flash. Do you value your life? Because
Right.
that is not life or death. And right now I'm hot. He was
right.
Like, ooh, I'll figure that one out myself. So I'm
Right.
just laughing because perimenopause is an evil witch. And it can really be challenging. So
Yes.
women can experience things from all ends of the spectrum. So changes in sex drive, brain function, hot flashes, changes in periods, either too frequent or too infrequent, weight changes, microbiome changes. I mean, everything changes. And
Everything changes.
everything changes. And so, yes, if you said to me, could this be? Yes. Could this be all of it? And it's a huge gamut, and women often miss the signs. And simultaneously, women also often blame perimenopause when it's something else. So there's a lot of interplay and overlap between perimenopause. And when I hit the skids for toxins, I was like, oh, perimenopause, but it was
Right.
toxins. So,
Right.
fix the toxins. And I was like, oh, I'm not
You
really
got
having
it.
hot
And that's what
flashes.
functional medicine is all about, finding that root cause. Like what's that funneling down to?
Yep.
And there are so many women out there who are so afraid to take hormones because it's been ingrained in us through the past decades that taking hormones equals getting breast cancer or ovarian cancer or something else, right? And so I can't tell you how many women come to me and they want to like literally, quote unquote, sweat it out when they don't have to, or perhaps they've inquired about hormone replacement therapy with their conventional doctor, their conventional OBGYN, and so many of them get the same response. This is just part of life. You don't need it. Just, you're going to have to just deal with it and get used to the aging process. Well, I call BS on that. Like, we don't have to accept any of that. And so I want to start by talking about the Women's Health Initiative, the WHI study, which was one of the most prevalent, largest study of its kind back it started in the early 90s. Yeah. But a lot of women my age are very unfamiliar with it and its outcomes, and then its reanalysis of what it was about. So can you just, in a snapshot, give us the lowdown on this?
Yeah. And I have to tell you, Jill, it was, even at the time when the study was stopped early, the reason everybody knows about this study is because it was stopped early. When studies are stopped early, people go crazy. And it was stopped early because what they noticed was in the subset of women who were on estrogen, 8 out of 1,000 got breast cancer, more than the baseline. And that was a statistically significant number. And so the study was stopped and everybody heard about the study. And then it was all we talked about. So the study looked at women who are at least 10 years away from menopause, who both had and didn't have their uterus. And if you had your uterus, you got one set of hormones, which included progesterone to protect the lining. And if you didn't have your uterus, you got only estrogen. I have to tell you, the study was, it didn't allow women who were significantly suffering from perimenopausal symptoms to participate, which nobody comes in my office and says, let me protect my bones. They say, I want to kill my husband.
Right.
So the wrong women were studied, and they were really far away from menopause. And the farther away from menopause you are, it does look like the risk goes up if you're going to start hormones and you're remote from that transition. So they used a subset of women who it really wasn't a good group. And then if you really needed the hormones, you weren't allowed to participate. So the whole thing was a little goofy. And so it was stopped early because they found this very small increase in breast cancer. But another problem with the study is that they were using non-bioidentical hormones. And let's talk about that for a minute, because essentially most hormones back in the day were from pregnant mare's urine. And if you take the first couple letters of each of those, Premarin, it was the most common form of estrogen on the market, which is from a pregnant mare. Now, if you're a pregnant mare and you get Premarin, you're going to be stoked because that's what you need. But if you're a woman, you shouldn't be using pregnant mare's urine because it's close enough to occupy the receptors, but far enough away that your body has to work extra hard to metabolize and detox off of it. So you make it even harder on the body. So bioidentical hormones look like what your body is producing, and non-bioidentical hormones look not like what your body is producing, but close enough that you can utilize it.
Walk us through the hormonal changes during premenopause through postmenopause, starting let's use a healthy woman in regards to all of her sex hormones or her sex steroids.
Okay. I'm going to go a little bit of a high level because this is so we can get really drilled in or we can go high level. So I'll start high level and we can certainly drill down. So when you're born, if everything's working, you have 2 ovaries and they start to function and put out eggs at puberty. And when your eggs are theoretically limited, meaning you have what you have and you're going to make what you make. And when you use up your store, you're done. Okay. That's the going conversation. So what goes into this is your brain says to your ovaries, hey guys, time to do your work. Your brain is putting out something called follicle stimulating hormone, or FSH. It goes to your ovaries and sort of lights them up, and your ovaries produce an egg. This is assuming everything's normal, right? And when you produce that egg, your progesterone levels go up. If you fertilize that egg, your progesterone levels stay up. And if you don't fertilize that egg, you have a period. Okay. That's big picture. And estrogen tracks a little bit before progesterone. So in perimenopause, what starts to happen is your brain is still saying to your ovaries, hey, get to work, give me an egg, except your ovaries are getting to the end of their functional span. So they are at times not able to produce an egg. So you're in the perimenopause, what happens is you're starting to irregularly ovulate because the ovaries aren't responding in the same way to these signals. So follicle stimulating hormone is kind of cranky. And it's like, well, if you're not going to listen, I'm going to talk louder. So follicle stimulating hormone goes up when the ovaries stop being as responsive. And that's why we use that as an indicator for, are you approaching menopause? What's happening? So the interesting thing is for reproduction, you like to see it in single digits. For perimenopause, you start to see it creep up. Once you're over 20, technically you're considered menopausal, and women are mad. Like, why are you calling me menopause? I still have periods every month, or I skip a period. That's because it takes a couple of years for you to fully deplete the ovaries and to catch up with what the brain has already recognized. So at a level of over 20, you're menopausal, which means your fertility is significantly decreased. It's not zero though, because you're still making eggs. So you could still potentially get pregnant in this perimenopausal period, which is really awkward for a lot of women because they think, oh, I'm over 45. I'm not fertile. You are. Be careful. So back to what's going on when you don't ovulate, you don't set off that chain of events that occurs that causes you to have a period. But because you're still producing some estrogen, you're making an estrogen lining in the uterus, and that grows. So now imagine that like a tower of blocks. If the blocks get high enough, it gets unstable. So as you have unopposed estrogen that's just making the lining grow, you're building a lining, but you don't get the signal to shed it. And now you have irregular bleeding because you're not, it's anovulatory, meaning not ovulatory, no ovulation, bleeding because the lining of the uterus has built a level so much that you just have to shed it. So that's kind of a nutshell for what's happening. But then sometimes you'll produce an ovary. You'll have a normal cycle. Now, as those hormones start to dip, that the precipitous drop causes issues for women. So sleep disturbances, crankiness, brain dysfunction, memory issues. It can alter the way you build muscle and your testosterone levels. So there's all these domino effects that start to happen for women, and those are very disruptive. Now, we can't say anything about perimenopause without talking about the adrenals, because your adrenal glands, as you approach menopause, there's a pathway in the adrenal glands where the adrenals pick up what the ovaries are not doing. So the adrenal glands has 2 major pathways. I'll super simplify it. One is fight, flight, or freeze. Keep you alive, keep your blood pressure up, and get you out of the way of that oncoming truck. That's prioritized, right? That's life. And then there's this other one, which is as you start to transition into menopause, you have DHEA turning into testosterone and estradiol. So you can get, and by the way, progesterone is over on the fight, flight, or freeze side. So you have your progesterone, your testosterone, and your estradiol being produced in the adrenals. However, because we're so stressed and because we don't sleep enough and we eat food that throws us off and we may not exercise properly, we're not as in balance. When you get to perimenopause, the adrenals can't pick up the slack because they're pretty overloaded. So as the ovaries start to quiet down, the adrenals should pick up, meaning you don't have to transition into menopause in a way that's challenging. It can be graceful, but it requires adrenals that are well cared for, essentially. And you can't start caring for your adrenals when you hit perimenopause. You have to really start ahead of time so that they're prepared.
That's really interesting. Okay, I want to talk about testosterone for a second, because a lot of women don't really understand the role of testosterone. Some women aren't even aware they have testosterone, but we do, and it gives us our zest for life. It helps us build that lean muscle mass. It's good for our brain health, among so many other things, right? But as we age, our testosterone, just as our estrogen goes down and our progesterone goes down, so does our testosterone. And I remember after having my 5th kid, and I was only in my early 30s, that my ovaries, because testosterone is also made in the ovaries, that my testosterone basically production came to a halt. Yeah.
There's a lot going on.
Yeah.
After 5 kids at a younger age, your body's been working really hard.
Yes. And I felt depressed. And I went to my OBGYN and I said, I feel really depressed. I don't want to have sex. I had this and that. My hair was thinning. And she tested me for testosterone. Now, this is the difference between a conventional doctor appointment and an OB and a functional medicine OB appointment is they don't really look at your testosterone levels when they take your blood work. Right. And so I was lucky that my doctor, who was a conventional doctor, saw my depression being correlated with having my 5th baby and tested for my T, which was in the tank for a 90-year-old woman. So I took synthetic testosterone because back then we didn't have choices. But what are some of the ways, let's say someone does have low T, what is, a normal range looks much lower than an optimal range, especially if someone's very physically active. And what are ways in which we can increase our testosterone?
So this is really interesting, Jill. So you can't talk about hormone balance and having proper hormone balance without also including toxins as a sort of parallel track, because your liver is responsible for taking care of and managing the hormones that we're producing. Our livers take care of that. And let's just spend a minute talking about how that happens, because that matters for when it's dysfunctional. So your body produces these hormones and your liver recognizes it as a substance to be metabolized. So in some level, your body recognizes your hormones as potentially toxic. And it goes through 2 phases. Phase 1 is where you change it from a somewhat inert substance into a metabolite intermediate that's actually more toxic than what it started out as, which makes no sense, but that's what the body does. And then phase 2 takes that very toxic metabolite and binds it. In the case of hormones, it methylates it, put on a methyl group, which is a carbon and hydrogens. So it puts it onto that, and that makes it not only chemically inert, but it makes it water soluble. You then take that bound hormone and put it into your gut and poop it out. This is the ideal world, right? Everything's working. Now, there's a lot of places things can go wrong here. Phase 1 is often quicker for women than phase 2. So you have this toxic intermediate that your body can't deal with, and your body's very smart. It's not going to let you get sick. It's going to say, whoa, we have this toxic intermediate of all comers for hormones. We're going to put you in the fat. These are the women who say, all of a sudden I'm gaining weight and I can't do anything about it. I exercise, I sleep, I eat right, and I'm gaining weight. This is some kind of toxins issue. And in perimenopause, hormones can act as a toxin. So one place it can go wrong is if phase 2 is too slow. There's tons of foods and supplements that can improve phase 2. Another place it can go wrong is if your liver's out of whack, if your liver's stressed, if it's dealing with too many things other than your hormones, if you drink, for women, I have a lot of women who are like, I don't drink more than 2 glasses of wine a night. And I'm like, that's way too much for women, because because it has to deal with all your hormones too. So your liver,
Right.
it's a toxin. So if you're drinking alcohol, if you're taking acetaminophen or Tylenol, if you're taking ibuprofen, these are all processed through the liver. So what another place it can really go wrong is if your liver is suboptimally processing. If you're exposed to other toxins and the liver's like, whoa, I really need to deal with that because that's going to kill you too. It's going to divert its attention from proper hormone balance into toxins. So if the liver is suboptimally processing, you can see lower testosterone levels because the sex hormone binding globulin, which binds to testosterone, is too high. That indicates that the liver's improperly processing on that side. And then there's another place this can go wrong, which is in your gut, because you've put these bound hormones in, and in theory, you should just poop them out. Great. However, if you have overactive enzymes in the gut that are produced by inappropriate bacteria, they're going to come around and separate that hormone from its binder. When you separate it, it can't stay in the gut because it's no longer water soluble. It's fat soluble. It has to go back into the bloodstream. You start the rat wheel all over. The body says, wait, I already dealt with you and I can't deal with you right now because I'm dealing with all these other things. Hang out in the fat as a storage depot. So there's a lot of places that hormone balance can go wrong for testosterone because there's just, it's a really intricate dance that the body's doing. And so you want to make sure that you're not stressing or challenging the liver. You're not exposed to other toxins that are distracting the liver, and that the gut's in balance, and that the adrenals are also in balance so they can pick up the slack of producing testosterone. There's a lot going on, right? Like,
Right.
how do you keep it all balanced?
Right. Yeah. It's all about that gut health, right? If the gut is not healthy, if you've got leaky gut, if it's impermeable, things leach out, they cause chronic inflammation, things get stored as fat. And, no wonder we don't feel good. No wonder our hair is falling out. No wonder our skin looks bad. No wonder we can't, achieve the health and fitness goals that we want. We have a lot of roadblocks. But when you were talking about the methylation process with the liver, what about those women, such as myself, who have the MTHFR genetic mutation? How does that come into play? And so many people don't even know if they have it because they don't even know about it to get tested for it.
Right. So let's start with, what is MTHFR? MTHFR stands for methyl tetrahydrofolate reductase. And in our bodies, that the methylation is how MTHFR does methylation, and methylation is one key way that we use phase 2 in our liver to detoxify toxic substances. So it's one of 6 pathways we can go down. So first off, about 40% of the population has 1 or 2 genetic mutations in MTHFR. If you have 1 mutation, say you have no mutations and you're just 100% effective at processing your B vitamins and methylating and doing this whole thing. Cool, you're 100% effective. If you have 1 mutation, your impairment is somewhere between 60 and 90% effective. So you're 10 to 40% less than your colleague next to you. If you have 2 mutations, it's somewhere between 30 and 60% gets done. So you're 30 to 70%, 40 to 70% impaired, basically. Right. And what that means is when you're exposed, I have 2 copies of MTHFR mutation.
Yep, so do I.
These increase your risk for poor metabolism of hormones, poor processing of toxins, issues with heart because it doesn't allow you to process your homocysteine through the whole process. You can build up in homocysteine, which is a heart risk factor for cardiovascular disease. The other branch of the MTHFR mutation increases your risk for more anxiety, depression, OCD, emotional disturbances. So you either have cardiac or emotional, or both if you have 1 of each. Like some of my kids have 1 of each, which I'm like, oh, I'm so sorry, but right. So it will impair your body's ability to take care of the things it's presented with. One way around that is anyone who has an MTHFR mutation, my response is, okay, plan on taking activated B vitamins for the rest of your life, because the B vitamins, when they're activated, they're ready to donate their methyl group. So your body doesn't have to do any work to get it to its prepped form. Just take it, you're done.
Right.
And it decreases the lift. It's not as heavy of a lift.
Right. And I think, we have to talk about folic acid for a second, right? How many women in pregnancy are given folic acid to take and they don't even know if they have this genetic SNP or not.
Right.
And it is the non-bioavailable form of folate. And
Right.
that's what we want.
There's so much in this, Jill, actually. So step one, you could have a genetic mutation that prevents you from converting folic acid into folate. Step two, if you have any alterations in your stomach acid, you can have difficulty converting folic acid to folate because you need adequate levels of stomach acid to convert. And do you know the number one decrease for stomach acid is stress? And we're all stressed. So anyone who's stressed with a mutation should, and I always say to all my patients who are looking at being pregnant, just take an activated form, take the folate so you don't even have to worry about it.
Right.
Get tested just so you're aware of what your risks are long term.
Right. And all of this affects our hormones on a daily basis. So I want to go back to estrogen metabolism. And I find this fascinating. I want to talk about those three different pathways that estrogen can take. And what I find out, I didn't really even know about this until this past year, that when you make that decision, like I did, to go on hormone replacement therapy. Now, I don't take estrogen yet because I'm still in perimenopause, but for when you get into the postmenopausal stage and you decide to take estrogen, there are these two pathways, the 2-OH, the 4-OH, and the 16-OH. Okay, now I might have listeners out there saying, what is she talking about? Because I was like that too. So what am I talking about? And why is that important to know before you take estrogen?
Yes. So if you're not the best methylator, and so there's so many things that go into this. I actually remember when I learned this whole pathway, because I didn't learn it in residency. I learned it in my functional medicine training. And I remember being horrified because, we're giving hormones to women right and left. Even the birth control pill needs to be processed. So basically, when you process your hormones through, it can go down less harmful pathways, which is the 2-hydroxy, or it can go down more harmful pathways, which is the 4-hydroxy. You do expect when you're processing your hormones to have some 4-hydroxy, but the majority should not be, because when you have the majority 4-hydroxy, these are more reactive substances that are more likely to be oxidated and cause oxidative stress and damage the DNA. And if all of that sounded like gobbledygook, basically 4-OH runs the risk of damaging your DNA and can be procancerous. So you want to not go down that as much as possible. And one way to support that is, well, there's a million ways to support it, but make sure that you're processing the hormones with providing the body with the methylation so that it can do that, and making sure the gut is intact so that you're not recycling, making it toxic and going down a pathological pathway.
So, but do genetics play a role in how your estrogen metabolites choose which path to go down? And can there be like a genetic mutation that signals the estrogen metabolite to go a certain way?
There definitely are, especially for, I don't know them off the top of my head, but there definitely are. These are single nucleotide peptide, SNPs that can make you more likely to process your hormones in one way versus another 100%, which is why it's great to know your genetics and your detox mechanisms.
So how come more doctors don't find out this information before they're giving hormone replacement therapy, especially estrogen, to women?
I think that especially in conventional medicine, they're about 20 years behind. Conventional medicine is 20 years behind. I mean, so in 2002, the Society of Endocrinology came out with the guideline that thyroid stimulating hormone, or TSH, should be below 2 for optimal function. I remember being at 10 years later, approximately 10 years later, maybe a little less, being at the Harvard course on fertility and women's care, and they had not adopted that standard. And this is almost 10 years later. So typically shifts in how to care for people are 20 years behind. It takes 20 years to really become commonly used And so I think the goal of functional medicine is get that data sooner, practice it, but there's a huge lag. And so it's not from maliciousness, it's more from that data has not trickled in yet, because one study generally doesn't change behavior. It has to be a groundswell of studies that prove and prove and prove and prove. And by then 20 years have passed, but then it becomes common.
Yeah. But there are tests out there that will look at this pathway. Because I've looked online and I'm considering doing it for myself, just because I'm a lab nerd anyway. I love seeing numbers and figuring out all the data about myself, but it can get a little bit overwhelming, right? But,
we use it a lot. I mean, we
do.
Can I say test names?
Yeah, of course.
Yeah. So we use the Genova complete hormones test a lot. It's a urine test that people do at home. And then you have to have a functional medicine provider order it, but it's looking at what's your 2, 4, 16 ratios. And then our goal, my job, is to optimize your gut, optimize your methylation, optimize how everything flows, and make sure, if we're giving you bioidentical hormones, it's easier to process, but you can still build up 4-OH. You don't want to do that. So we're watching, how do you do with that? Most of my patients are on things that inhibit beta glucuronidase, which is that enzyme in the gut that disattaches hormones and makes them recycle. Most of my patients who take hormones are also on that.
I love that you do that test and you really look at that. That's great. All right. So now I want to talk about the decision on whether or not someone decides to take HRT or BHRT. Now, I will say that
there's no discussion.
Well, and I am in agreement with you, but for a lot of people, it's a really difficult decision, especially if maybe a family member, like their mother, their grandmother, or their sister, had breast cancer, or even if they're not a carrier of that gene. Like I was saying in the beginning, that WHI study made us all really afraid. And so I will say that hormone replacement therapy is covered by health insurance plans, right? But to some degree, but bioidentical hormone replacement therapy is not.
Not true. No, because so estradiol patch, bioidentical, that's covered by insurance.
Oh, that's good to know.
Progesterone, micronized progesterone, is covered by insurance. What's not covered by insurance for women, which burns me, is testosterone. So if you need testosterone, the only levels that are on the market are male levels, which are way too high for women. So testosterone is not covered, needs to be compounded, because the levels at which we need it is so much less than men. But no, you can absolutely get things covered. You can't get the creams covered. So if you want to compound a cream, have it be really specific and drill it in, that won't be covered.
Yeah, my BHRT is not covered by my insurance plan. So perhaps it's, state by state and insurance company by insurance company, but always good to double check and ask.
Yes.
So a patient comes into you, she's at that point where she cannot deal with the lack of sleep, the night sweats, and so on. And she wants to have that discussion with you.
Yep.
And she's confused between HRT and BHRT. What's the discussion you have with her?
So in our practice, except for the birth control pill, we are not using hormone replacement therapy unless it's bioidentical, because from a philosophical standpoint, we feel that it's not right to give women something that's so hard for their bodies to break down. So we don't, except I do prescribe the birth control pill, which is not bioidentical. So setting that aside, I'm not giving women anything unless it's bioidentical. It's just not negotiable.
Okay.
I'm not comfortable with it. I think it's harmful. So, so the discussion is more about, is it appropriate to start hormones in general?
Yes.
It's always going to be bioidentical. So the things that we're looking at for, is it appropriate to start hormones, is have we done everything we can to optimize your adrenals? Because remember, your adrenals are going to pick up the slack. So anything that'll support the adrenals. So avoidance of alcohol, avoidance of sugar, optimizing the eating plan, acupuncture, sauna, Epsom salt baths, body work, adaptogens. These are specific substances that boost or quiet the adrenals depending on what they need. So optimize your poor little adrenals, make sure you're meditating, not a stress ball, exercising, all that, right? And then we've done that and you're still having trouble. Then we want to peel off. If you're having periods, then it's unlikely that you're going to need estrogen, but you might need
Right.
progesterone.
Mm-hmm.
And so if women are experiencing mood changes, sleep disturbances, swings, and even before they get into perimenopause, you can have disturbances in progesterone. So we first start people on an extremely low dose, which is derived from yams, which is kind of interesting. It's a cream, not covered by insurance. It's a more of it's a supplemental remedy. And if that doesn't work, then we move up to oral progesterone and start at 100. It's covered by our insurance. I'm in Massachusetts. And so 100 milligrams of micronized progesterone, take it at night. It helps with sleep. It's relaxing.
Yep.
And you can go up to 200. And what I say is, let's check you 4 to 6 weeks after you start. And then if you're in good range, cool, we'll check you in like 3 to 4 months. And if you're still in range, we'll check you a year later. We'll just sort of keep an eye on it. And then for estrogen, what we're doing is adding it in for women when things become problematic. So and often the progesterone can impact sleep and hot flashes. So it can be impactful for women. And then the estrogen can be added in when women are really at the tail end of their menstrual life. You don't have to wait till the end, but typically women wait till the end.
Right.
And then again, monitor that.
And talk about the multiple health benefits of taking estrogen, because so many people don't want to take it, and it's their personal choice, but let's speak to all the amazing things that it does for us.
Yeah. So I think the goal of it is to use the lowest dose that does the job.
Yeah.
Okay. And it's so funny. I have a patient who has no adrenal glands, and her periods, as a result, she hasn't had a period in 3 years because your adrenals play a huge role in normal hormone cycle. So her hormone levels were menopausal, and she's 32. And I said to her, I'm not trying to get you to reproductive levels. I'm trying to get you to appropriate postmenopausal levels so that we protect your bones, we protect your brain, we protect your heart. So there's tremendous value in hormones when it's appropriately managed to absolutely keep bone health, to heart health, and brain and sleep and mood. I mean, it's like everything. It's like life, sex drive,
right?
Too.
Absolutely. And so then when does testosterone come into the picture? And then do you favor pellets over the cream or a patch?
I'm commitment phobic, so I've never liked the pellets, because if you don't like the dose, you're stuck with it.
You know what? I when I started on testosterone, after I took the synthetic many decades ago, I took a break and then I started on pellets. And I got to tell you, I agree with you. Pellets were really rough because it's shot me up to over 900, which is like it's like my boys who are athletes, right? And and my hair started to really shed at that point.
Yeah.
And because the testosterone converts to DHT. And
speak to that for a second, because I talk a lot about hair loss and hair regrowth, and I've been on a 4-month journey, and I'm finally seeing hair growth back and stability. But that testosterone
pellets are too high of a dose on the cream why is it triggering hair shedding?
It's basically male pattern baldness. You're starting to, if you kept on with it, you would have the shedding in the crown. Right. Because that's the impact of testosterone on hair. So and your voice would deepen over time and your clitoris would get bigger. So we don't want any of those things.
Right.
So it's important. It is important. So you asked like, what do I use? I tend to use testosterone in a compounded cream.
Yep.
And I'm always checking levels. It's like, if we're doing that, we're going to check the levels. And no, here's the thing. Women are going to tell you if their levels are off, because especially with testosterone, you get ragey, you get hair growth where you're rubbing it in, which is why you should rotate it around.
Right.
If a woman says, oh, my voice is deepening, I'm like, your testosterone's too high. So what we try to do is do it in a cream, do the low dose test, tweak. Test, tweak. So that usually takes anywhere from 6 to 12 months to find your dose, but any number of things can throw that off too. So you've gotten to your dose, you've been on it for years, but then you have a major life change, major car accident or move or something really stressful, illness. And all of a sudden, these levels are either way too high or way too low. It's because you've altered your adrenal participation in the matter too. Because don't forget, if you have adrenals, they're picking up, they should be doing some of this work. And if they're not, it's because they're fatigued.
Right. Yeah, I switched to the testosterone cream and I am much happier, and I go at a much lower dose.
Yep.
My hair is stable. I don't have that, I didn't have rage, but I definitely remember feeling like a little bit more jacked up.
Yeah.
But I did have some great weight resistant training sessions.
Yeah.
Right. Not that I want to get jacked up that way either, but let's talk about DIM, because a lot of times when people are on hormone replacement therapy, they're also given DIM to take, and some people aren't. So I want to have you explain what DIM is and why it's an important component to this equation.
Yeah, so DIM is a precursor of indole 3-carbinols, which is what you get when you eat broccoli or cruciferous vegetables, except my patients are always like, can I just eat more broccoli? And I'm like, please eat more broccoli. Go ahead. It's good for you. And you would need to eat a bathtub full of broccoli to equal what you could get in a pill. And so trying to remember, one of them, either DIM or I3C, is less shelf stable. So one of them, either DIM or one of them is less stable and they convert. So I'm trying to remember, I've totally blanked on that, but DIM and I3C help you process your hormones properly. So as I was referring to that inhibition of the beta glucuronidase, it's done with DIM, I3C, and we also use calcium D-glucarate. So these are inhibiting the hormones from being unbound so that you can continue to excrete them in a proper manner, so that you're not building up again, shunting it into the fat, making the liver work harder. So that's how we largely use it.
Okay. And speaking of excretion, is it normal that, or should a woman have a bowel movement every day to help excrete all of these toxins? Because I'm a carnivore and I coach a lot of women in the carnivore and animal-based space. And when you go carnivore or heavily animal-based, you might not poop as much as you normally did because your body is actually utilizing all these bioavailable nutrients. And I always, focus on how to get those daily bowel movements back, especially for women because of the estrogen.
Yeah. So I remember in med school learning about what's called the oroanal reflex. And I thought that was hysterical. Eat and poop. Now, by that time, I was already a celiac and not pooping regularly. So when they said, every time you eat, you should poop, I was completely blown away. I was like, what? Who does that?
Yeah, that's a lot of pooping.
Yeah. So, but when you stop and take a step back and think and go, you're eating 2 to 4 times a day, depending on your eating plan. And even as efficient as you can get, you still have waste, and moving that waste is critical. So my bottom rung of acceptable is once a day. If you can poop every time you eat, that would be amazing and ideal. And so, it's difficult when you're on a carnivore diet to get enough fiber, because that's also helps loosen up the stool, make it less packed, help you move. So that is a challenge, no question. I usually fiber, magnesium, aloe help move you along. You can do colon hydrotherapy. Sometimes you need to retrain the gut to move regularly.
Absolutely. And also the gallbladder, right? Because when if you're eating a bad diet, the standard American diet, your gallbladder can become very lazy because it really doesn't have to do too much work. Right. But when you start going low carb to animal-based or to carnivore, you don't have all that fiber in there. And all of a sudden you're like to your gallbladder, knock, 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 wake up, you got to do your job now. And it's very hard to get it going again. So yes, but pooping is something I work on with my clients all the time. And whether they're eating a lot of vegetables or not, but so important to move those toxins out of the body.
Yeah, it's critical.
So I want to talk about cancer, women who've had cancer, and then maybe they were young and they had cancer, maybe breast cancer, ovarian cancer. Now they're sort of being pushed into menopause quite early. Are they candidates for taking hormones? What does that look like?
All right. So we're going to tread really lightly here.
Yeah.
So if a woman has had, so let's go into different categories. So if a woman has had BRCA1 or BRCA2 related breast cancer, which is a gene mutation that raises your risk for breast and ovarian, if a woman has had any cancer related to that, then the knee jerk would be no, because the estrogen will stimulate the cells to grow. So you don't want to do that. So that's one category. So I would say any woman who's had BRCA1 or 2, I would not give them estrogen. I think it's unsafe, that they're at risk.
But what about progesterone and testosterone?
So progesterone and testosterone are both precursors in the adrenals for estradiol. And so, no, I wouldn't necessarily give those at therapeutic levels, because you can convert both of them into estradiol.
Right.
You can give something called 7-keto DHEA, which can help mitigate the effects of lack of hormones. You can give that because that will not convert to estradiol. So that would be reasonable. And then working on adrenal health is critical. And then the other thing that you want to sort of put alongside that is any woman who's had cancer and gone through chemo and radiation has a boatload of toxins that we need to get rid of. And getting rid of those will also help with how they feel, because they're super toxic. You could even argue some major causes of cancer are toxins in general. And so you'd want to do a full evaluation and make sure you're optimizing the liver, detoxing them, rigorously detoxing them. So that's the BRCA category. Then there's the non-BRCA estrogen receptor, progesterone receptor positive cancers. That's not a candidate for estrogen either, because you don't want to stimulate that cancer cell to grow again. And then there's the estrogen progesterone receptor negative cancers. That's a possibility. And I say possibility as opposed to definitive, because when you've had breast or ovarian cancer, everyone is pretty jacked up and nobody wants to do anything that's going to mess you up. And so, so you really have to understand. I mean, I wouldn't do any hormones without detoxing a woman first. And that can take a couple of years, because you really need to make sure the liver's working, the gut's working, the adrenals are working. I call that the holy trinity. Liver and gut.
Yeah, that makes a lot of sense. So let's talk about lifestyle factors now. Yeah. So now we've talked about women who are candidates for hormone replacement therapy, whether it's HRT or BHRT. And we've talked about women who have cancer who might not be candidates, who definitely, it sounds like, are not candidates. Yeah. What are lifestyle factors for both groups of women in terms of managing their hormones?
Sure. I love this. So there's so many things women can do that aren't straight hormones that make a difference for hormones. So look at the foundations of life. So are you eating the right food for your body? People often say to me, what's the best way of eating? Right. And I'm like, that really honestly differs between people. But if you've had a history of cancer personally, then you're going to want to lean away from as much flesh and lean towards more cruciferous and add in more vegetables, but that's more just a broad brush stroke. So I wouldn't subscribe to that there's one way of eating for every group, but generally minimally processed, low sugar and low to no alcohol is meaningful and impactful for most people. Foundational behavior. Make sure you sleep enough. Now, if your hormones are out of whack, it can disrupt your sleep. So what can you do to help your sleep? Fix the adrenals, support the adrenals, give them what they need. That's acupuncture, massage, even meditation, breathing, Epsom salt soaks, adaptogens. There's a long line of things, and things that stress the adrenals. We go back to the platform behaviors. Don't eat a lot of sugar, don't drink alcohol, and don't be a stress ball. So make sure you manage the inputs. And then there are some estrogen receptor mimickers. I'll say they don't turn it on, but they can occupy the receptor and make your body think that it has estrogen so that it quiets the symptoms down. So Siberian rhubarb is one, and it was studied, and they actually did a head-to-head with hormones, and it held up well with hormones. So that's another product that you could look forward to manage if you're not a candidate for hormones. But it's really about all the platform things, because if your adrenals are, and getting rid of toxins, because toxins will shut the system down and put you into a state of inflammation and stress.
Right.
increasing your symptoms.
So I think this is a great place to talk about your new book that you co-authored, which I see behind you, called Dirty Girl, Ditch the Toxins, Look Great and Feel Freaking Amazing. Great title, by the way. I probably say that to myself twice a day. Right. Right. So tell us about your book and how you got so into detoxifying.
Sure. Well, I mean, I always think it's always personal, right? So I hit a health wall and gained almost 10 pounds, lost a ton of hair, and had a rash on my face that was unremitting. And really, as we untangled it all, it got very clear that I had too many toxins in my system, and they had reached a point where they were now clinically relevant and causing problems. I had them for years, I'm sure. Look, I'm a child of the 70s. I grew up in the 70s. We ate sloppy joes for dinner. And then the 80s, we had microwaves. Like, these are things I grew up with. You microwaved in plastic. So I was piling things on as a child, and then went to med school, was very stressed, developed celiac, had gut dysfunction. So there's a lot of layers to this, but I really hit the wall when I was 49. And so I did all this testing on myself, and I said to my husband, I am such a dirty girl. And I'm the poster child for healthy living. How is this possible? And so what we said was, if it happened to me, and I am like crazy about super healthy living, it could happen to you. So let's make a roadmap so people don't have that happen to them. Don't do what I did. Read the book, make changes, avert it, because it is coming for most of us in the form of fatigue, menopausal issues, weight gain, bone loss, cardiometabolic disease, cancer. I mean, these are all of those contribute to those states of being. So we wrote this book so that people didn't have to go through what I went through, because it was pretty awful.
Yeah, that is one of the areas of focus I do talk about with my clients is the toxins, the incoming. You're spending money on me to help health coach you. You're spending money on functional medicine doctors to get all of the data that you need so you can make educated decisions.
Yep.
You're spending money on this great, organic food, but maybe your laundry detergent is, Tide, or maybe you're using, Dove shampoo and conditioner and your nail polish. Like, how important, like, how far do we go? Is this all or nothing? Because it gets expensive.
So it isn't an all or nothing, but it is a constant process of improvement. So take whatever you're running out of. Well, okay, Jill, let's address the money first off. It is expensive to convert into sustainable, organic, non-harmful, non-toxic. It is more expensive. However, what you're stepping over is that it's actually a lot more expensive not to. I think it's something like 1 in 3 Americans has either diabetes or insulin resistance or prediabetes. That's very costly. Yes. So you can pay now for something that's more expensive, or you can pay later to deal with the issue of it.
Right.
So I would say it's actually cheaper in the long run to do a more sustainable approach, but you have to look at it that way.
Yes, it's a mindset. It's definitely a mindset thing.
So the way I look at it is, Rome wasn't built in a day. You're not going to overhaul your house in a day, but what you want to do is figure out what you're running out of and level to the highest level you can. Okay. So whatever's, look, I have 4 kids. You have 5. Did you stop at 5 or did you keep going?
Oh, no, I stopped.
Okay. So I have 4, you have 5. I'm assuming your youngest is out of the house already almost, because at least 19. So but when you had 5 kids at home, you were doing a lot of laundry. So you're going to run out of laundry detergent way before someone who is just living alone. So whatever's that thing that you use a lot of, that's the most impactful thing to level up on. Yeah. And then as you run out of your under eye cover up, your mascara, your lotion, whatever, your floor cleaner, I don't care what that is. As you run out of any product that you need to buy, level up.
Yeah, that's great advice. And I often tell my clients to download this app. I love this app, and there's multiple apps out there, but I use Think Dirty. Yeah. And I think it's great. You can plug in the product that you actually want to find out about, or you can even plug in just the category of something you're looking for. And it gives you red, yellow, and green sort of warning color signs. And I think it's very, very helpful. And I agree. As I used up things, I replaced them with better for you options. Yeah. And like this all goes back to balancing your hormones. It goes back to finding out, do you have an MTHFR genetic SNP or maybe another SNP, right? And all of it matters. So, it's like if you take your car in and to try to fix the engine, but you're just going to fix one part of it, right? It's just not going to work as well. No. So eventually you got to fix the entire engine.
Yeah, I would say take a systems approach. Like you matter and you're worth it.
Yeah.
So, and the other app I love is Environmental Working Group, or EWG. And I just heard that they have an agreement with Amazon to showcase products. If you're searching, it'll show up if a product is EWG certified. So they're similar to Think Dirty, which is great because everyone uses Amazon and you should be using either Think Dirty or EWG. So they make it easy to figure out, is what I'm buying actually clean? And I really feel like if enough people vote with their feet, companies will get the message that, hey, my consumers don't actually want all these toxins.
Right.
How do we level up as a company?
Right. Absolutely. All right. So we're coming to an end and I have a few more questions. These are a little bit more fun, but what are your top 3 foods every menopausal woman should keep in her diet?
Well, is a category a top 3? So any cruciferous vegetable, broccoli, cauliflower, kale, cabbage. These are fantastic foods because they get you that DIM, indole 3 carbanols, to help you balance your hormones. And so those would be, any within the category of the cruciferous or brassica vegetables, any and all, as much as you can.
Okay. So my only concern with that is, as a carnivore, is that I know that there are a lot of oxalates in dark leafy greens. And when you have the MTHFR genetic mutation, one of the things, the leading doctor on that is Dr. Ben Lynch, right? Mm-hmm. And he wrote a great book. And, he always is trying to push dark leafy greens. But then he was on a carnivore podcast and he said, I kind of understand why you wouldn't want to have such high oxalate foods in your diet. Mm-hmm. So maybe perhaps for some people. So I do think, some of the brassicas and cruciferous veggies, but if you have a problem with oxalates and you know about it, that might not work for you.
Right. So that's absolutely something to keep in mind.
Yeah.
And then if you're going to eat flesh, that it be the cleanest flesh possible and grass-fed, grass-finished for beef.
Absolutely. Yeah. And so what are some other foods?
That's like what I eat, right? Like the meat and vegetables, and then a little bit of grains, but really for me, it's about food that looks like itself and is minimally processed. So
absolutely.
I think that whatever is bringing you joy in terms of food would be, my third category would be some kind of fruit, but probably just berries.
Yeah. Keep it low glycemic for sure. Yeah. A lot of studies on high fructose fruits, because there's obviously fructose in fruit and how it's creating such high levels of uric acid, which can cause a lot of problems for people. But that's a whole nother podcast. What are your favorite supplements for menopausal women? Some supplements have to be given when you are tested and you have a deficiency, but there are some that probably could be for almost everybody.
Yeah. Oh, a ton. So that one I mentioned that has the calcium D-glucarate, the DIM, the indole 3 carbanols, that's one of my favorite, absolutely favorite. And then I really feel like everybody needs support with the B complex. So an activated B complex and vitamin D, because vitamin D regulates your gut, helps your bones, helps your mood. It's like the everything hormone. So, and it is a hormone. So those would be some of my favorite for women. And then adrenal support. So adaptogens, we use a ton of adrenal support in our practice, both to boost and to quiet, depending on what the needs are.
Yep. I used to be a huge fan of maca root. That really helped me when I went off my testosterone medicine, 30 years ago, and helped me get some testosterone going again naturally. So totally agree with the adaptogens. All right. My last question for you is, what are 3 things that the women listening to this podcast can do today to help further and educate themselves about HRT and BHRT? So
3 things. So 1, reject the conventional wisdom that you're supposed to fail as you get older. Really I just reject that. Like you called BS on something, I flatly reject that you're supposed to get worse as you get older. So reject that along with me.
Yeah, I love that.
And say, okay, I'm really meant to be in balance. 2, find a provider who you resonate with and who matches your beliefs. And 3, I would say work on your adrenal health while waiting for that provider, for your appointment, because the healthier your system can be, the better your menopausal transition and experience will be.
I love that. Great, great answers. So we're coming to a closing, and I know you have a free gift that you'd like to offer all of the listeners. So tell us a little bit about that.
Sure. So as you look at cleaning up your life, it can feel really overwhelming where do you start? So as a companion to the book, we created a non-toxic guide to healthy living, which is all about, well, what pans should you use and what makeup should you use and what's the best sauna and things like that. So that's all in the non-toxic guide to healthy living. And that's at 5journeys.com/promo, PROMO, and 5 is spelled out.
Right. And I am going to make sure I put all of these notes, including a link to the free gift, the guide, in the show notes. So all of you can be able to find that whenever you want. And thank you so much, Dr. Trubow. It was such a pleasure to have you on my podcast to really break this down into layman terms so that, we can really understand, because it is overwhelming information and it's a lot of science. And sometimes people just are like, I'm too overwhelmed. It's stressful. I'm just not going to even think about it or learn about it, but it's really important information.
Thank you. It's been a pleasure being here, Jill. And also we have a podcast called the 5 Journeys Podcast. So
nice.
I think people listen to your podcast probably would like ours too.
Yes. I'll put on all of your social media information, your podcast, so everyone will know how to find you. Because if you are looking for a functional medicine, well, you don't really practice the, OB/GYN component,
not OB,
which is, not OB, just the GYN. But a lot of women are looking for that, and I will make sure that they know how to contact you. So thank you again. It was a pleasure meeting you. And thank you to everyone for tuning in to another episode of the Health Trip Podcast with me. And everyone, take care. Bye-bye. Thank you for joining me. I hope you enjoyed the podcast. Lifestyle changes can be hard and overwhelming to make. By building your support team of functional medicine doctors, therapists, and health coaches, you can reach your optimal health goals. Be sure to check out my other podcasts. Until we meet again, stay healthy.